Good morning. Welcome to the third Annual Cardiovascular Symposium presented by Western Kentucky Heart and Lung Research Foundation and Educational Trust in partnership with the Medical Center and the Heart Institute. Once again, the staff here of Western Kentucky Heart and Lung will serve as your ambassadors for the day, so please feel free to seek them out for any assistance you may need. Please note on the sheet in front of you the order of today's program as well as breaks and lunch times. We're excited to present an excellent group of speakers and panelists for today's event, and it is now my pleasure to introduce the driving force behind this event, our President and CEO, Dr. Mohammed Kazimuddin.
Good morning, ladies and gentlemen. First and foremost, I would like to thank you all for attending our third Annual Cardiovascular Symposium. On behalf of Western Kentucky Heart and Lung Research Foundation and Education Trust, it's my pleasure to welcome you here for an exciting day of collaboration and learning. I would now like to acknowledge the hard work and dedication of a group of individuals, without whom this event would not have been possible. First, I would like to thank the faculty of Western Kentucky Heart and Lung. My colleagues are a group of excellent physicians who are dedicated to improving and maintaining a high quality of education and patient care. Additionally, I would like to thank our administrator, Vivian Grise, and her associates, especially Kate, for planning and preparation that made this event possible. Next, I would like to express my sincere appreciation for the director of this event, Dr. Singh. His talent and dedication to the field of cardiovascular medicine is evident through his improvement in scholarly activity on multiple levels. Not only has he been at the forefront of the planning for this year's symposium, but he also served as the Director of Research for the Cardiovascular Fellowship Program. Over the past few months, Dr. Singh has been working with the residents and the fellows to evaluate each abstract submitted to the symposium poster presentation today. Under his direction, 10 of the abstracts being presented today were also submitted to the Kentucky chapter of American College of Cardiology. He deserves a big round of applause. Next, my sincere appreciation to the president of CHC, Connie Smith, for her support, under whose leadership the medical scene at Bowling Green has evolved dramatically for the better. Dr. Don Brown, our Director of Medical Education, played a major role. His relentless efforts to bring in the medical school, residency, and fellowship program to our hospital was not an easy task and was indeed a monumental achievement. The program is now well anchored. Thanks to all the members of our GME committee for their contribution. Dr. Shane O'Keefe, Dr. Sam Hartcastle, Dr. Grau, Wade Stone, and Jake Barrick, our coordinator, and his staff. We all at WKHL feel very honored and privileged to be part of this team. We all share the same vision for growth, expansion, and academic excellence. Towards this same cause, the Western Kentucky Heart and Lung Research Foundation and Education Trust was established as a non-for-profit organization, striving for constant growth, improving patient experience, and trying to provide the most comprehensive, all-encompassing cardiovascular care with excellent clinical outcomes has always been our motto at WKHL. Our annual Cardiovascular Symposium serves as a mode for sharing evidence-based educational activities that will provide clinicians with information on the most current treatment guidelines and techniques in the field of cardiovascular medicine. In an effort to provide further opportunities for the medical education in the community, Western Kentucky Heart and Lung will be expanding the program into a state-of-the-art facility featuring a multi-use auditorium. Once completed, this facility will house all future symposiums hosted by Western Kentucky Heart and Lung. We believe this expansion will enable us to continue passing the skills we have cultivated in our many years of experience to the next generation of rising clinicians. I would like to acknowledge the support of TIFF District and Bowling Green officials, including Doug Gorman, as well as Executive Vice President of CSC, Jean Cherry, and are thankful for the contributions which have allowed for the continuation of this expansion. In conclusion, I would like to thank the group of renowned speakers joining today from around the country to share the latest changes and advancements in the cardiovascular field. First, I'd like to thank my friend and colleague, Dr. Asim Vashist of Connecticut, who has been involved in the past 2 cardiovascular symposiums, as well as supporting the cardiovascular fellowship behind the scenes for the past 2 years, providing support and innovative ideas. He deserves a round of applause. I would like also to recognize Dr. Christopher Ellis from Vanderbilt, Dr. Stevenson from Brigham and Women's Hospital in Boston, Dr. Courier from the University of Michigan Health System, and Dr. George Davis from University of Kentucky. Lastly, I have to say I'm extremely proud of my colleagues, Dr. Abdul Wahid, Dr. Shoaib Akbar, and Dr. Jacqueline Dawson, for their willingness to share their expertise as speakers in today's event. Please join me in welcoming these individuals with a big round of applause. Thank you again for being here. I sincerely hope you enjoy the day we have planned for you. Now, I would ask our director of the symposium, Dr. Annual Singh, to take over the podium.
Good morning and welcome to Cardiovascular Symposium 2017. This is a very exciting time for us. We sometimes lose track of all the progress we have made, especially in the last 3 years, and especially with the pressure we face every day in taking care of our patients. It's remarkable to think how far we have come. Just in the last 3 years, we've started residency program and fellowship programs. On the clinical side, our TAVR program has really taken off. And very soon, we're going to be starting our ASD and LVAD programs. Our research is expanding, and you'll get a glimpse of some of the research that our medical students and residents have been involved in. We're moving from being a community hospital providing excellent patient care to an academic medical center, which is more than a regular hospital. We're teaching healthcare professionals, including students, residents, fellows, technicians, nurses, and other experts to advance healthcare, which certainly is a multidisciplinary approach. I would like to take a moment to recognize not only our excellent clinical faculty, but also the administration, teaching staff, nurses, and technicians for opening new doors. So thank you. Our Cardiovascular Symposium is very much in keeping with these goals and vision. We have experts from all over the country to provide the latest scientific update, new technology, approaches, and guidelines required to improve patient care. If I can have all the speakers please stand up and be recognized. Thank you so much for finding the time to come here and share your knowledge and experience with us. Thank you. Now, the symposium today will have 7 sessions. Each session will have a moderator, and the moderator will be introducing the guest speaker and the panelists. Questions will be taken from the audience after the talk. So if you have any questions, please go to the microphone closest to you and direct that question to either the moderator or to the speaker. New this year is poster presentation, which we're very excited about. Our medical students, residents, and fellows have worked really hard in putting together some very interesting and informative abstracts and posters, so please spend time with them. Winners will be announced in the end. Also new this year is the late clinical breaking trials, which our 2 senior fellows are presenting. At the end of the symposium, Ms. Adina Husic will be giving you your certificate of participation. With that, actually, I would like to invite our first speaker. Before I do that, I just want to say our schedule is a little bit out of order, so just bear with us. The first speaker I would like to introduce is Dr. Lynn Stevenson. Dr. Stevenson is the new director of cardiomyopathy and heart failure at Vanderbilt University Medical Center. And this is our first lecture since she has moved there last week, so we're feeling very special, Dr. Stevenson. Thank you. Before moving there, Dr. Stevenson was at Brigham and Women, and she directed the cardiomyopathy heart failure program and was the professor of medicine at Harvard Medical School. She was there for 24 years after beginning her career at UCLA, where she helped to initiate their heart transplant program in 1984. She's an author on over 250 original publications and editorials, and has been a writing member on 30 US national guidelines related to heart failure, cardiac transplant, implanted devices, and shared decision-making and palliative care for advanced cardiac diseases. She also does consulting for FDA, CMS, and JCO. Her research has focused on the physiology of relieving and preventing congestion in heart failure, the tailoring of therapies for individual patient profiles, including bedside clinical assessment, and strategies for triage for high-risk or high-resource interventions. Her work has established the clinical utility of the 4 hemodynamic profiles of heart failure and the Intermex profiles of patients evaluated for advanced cardiac therapies. She has played leadership role in NHLBI-sponsored studies for strategies of medical and device therapies in advanced heart failure. She has also been involved in National Heart Failure Network and the SCAPE trial of hemodynamically guided therapy in hospital, which we all are very aware of. She's also been involved in the Intermex registry of ventricular assist devices, and she has mentored 2 networks of NHLBI young investigators. As Director of Cardiomyopathy and Advanced Heart Failure, she will focus on advancing personalized care for cardiomyopathy through the integration of clinical and molecular evaluation, serial assessment of disease progression, attention to patient-reported symptoms and function, and incorporation of patient goals into approach to advanced diseases. I would like to invite Dr. Stevenson on the stage. Please give her a big hand. Our first panelist for the session is Dr. Dawson. Dr. Dawson is the Heart Failure Director at WKHL. She's also the Associate Program Director for Cardiology Fellowship at Western Kentucky Heart and Lung. Dr. Dawson, please come on the stage. Our next panelist is Dr. Muhammad Abdul Wahid. Dr. Wahid is the Director of Interventional Cardiology and Associate Director of Advanced Heart Failure at WKHL. Please welcome Dr. Wahid. Next, I would like to invite Dr. Sheth. Dr. Sheth is one of our very busy community practitioners who is very liked as well. He takes great interest in teaching students and residents. He specializes in internal medicine and geriatrics, so please welcome Dr. Sheth. Dr. Melinda Joyce. Dr. Joyce is Vice President Corporate Support Services for MedCenter Health, the parent company for the Medical Center Bowling Green. Her main responsibilities are focusing on the quality, population health management, survey readiness, patient safety, patient satisfaction, and performance improvement initiatives. She works closely with the medical staff to improve patient outcomes, specifically related to heart failure and readmissions. Previously, she was the Corporate Director of Pharmacy for MedCenter Health. Joyce is a graduate of University of Kentucky College of Pharmacy. All right, with that, I would like to have Dr. Stevenson take the stage.
Well, thank you very much. It's quite a pleasure to begin my career here in the South in Bowling Green, beautiful, beautiful Bowling Green. And I also very much appreciate your forbearance in changing the schedule. It's an elder rescue from the hurricane threat is why I'm going to have to leave early today. So what I'd like to do, I also want to thank Kate very much for her forbearance in helping me with the slide format and some last-minute changes that were based on some discussions at dinner last night with my faculty colleagues. One of the first things that we've all become aware of since I began in this field is the prevalence of heart failure. And in fact, if you look around you, all of you who are 40 or older have a 1 in 5 chance of getting heart failure in the remainder of your life. So you can decide which one of those you are. It is pretty sobering for all of us as well as for our patients. Recognizing how prevalent it is, I also want to discuss a little bit about how the profile of heart failure has changed since I began in heart failure about 35 years ago. I'm going to focus on the central role of pulmonary pressures in heart failure, regardless of what the ejection fraction is. So this is the 1 in 5. The key points I'm going to focus on, first of all, that the journey with heart failure has changed, and maybe the name should change also. Congestion dominates the clinical symptoms. Rehospitalizations are usually due to recongestion, and I applaud all the effective efforts of Dr. Joyce and colleagues here in terms of addressing rehospitalizations. Managing pulmonary pressures, in fact, will lower event rates even further. Progression of heart failure with preserved EF, in fact, is more similar than different from heart failure with low EF. And lastly, that we still will walk our patients home. So to talk a little bit about the changing journey with heart failure, if you look on the top, this is the early era when I began in heart failure. In fact, people were referred for transplant. We usually didn't see them before then. And they basically progressed pretty quickly if they didn't get a transplant and died. And this is largely because they died suddenly so quickly. We had very few people who lingered with advanced heart failure. We didn't need to think about hospice, et cetera. They were all dead by the time they had had class 4 symptoms for more than a few weeks. Contrast that now to our current era. We now treat patients with stage B heart failure because we actually have medicines that help people before symptoms develop. Stage C, some patients in stage C now go back to an earlier state, what we call heart failure better EF. And that, in fact, is about 1/3 of our heart failure clinics now, are patients who have improved from an EF below 30 to an EF above 40. It's kind of a new era altogether. But on the other hand, they live longer with heart failure, which is good in stage C, but then they gradually develop RV failure, the cardiorenal syndrome, and they linger and linger and linger. So they not only live longer, they also die longer with heart failure. And there's much less sudden death, which is a very good thing in the early stage of disease, perhaps not so good in the later stages of disease. So it's a very different picture than what we saw 20 and 30 years ago in heart failure. So think for a moment, do we have any trouble with this term heart failure? Well, first of all, the oxymoron of asymptomatic heart failure just never makes any sense to us or patients. It's kind of like recurrent sudden death for the EP people. The idea of advanced heart failure, how can failure be advanced? Failure is failure. And heart failure with preserved ejection fraction, I think, is one of those terms that really bothers us the most. The questions I have trouble answering from my patients, but I never have any symptoms, so how can I have heart failure? When my car fails, it just stops at the side of the road. So how can I feel fine with heart failure? Or I was tuned up in the hospital 2 years ago, I felt well since, so I can't have failure, do I? My EF improved to almost normal, so why isn't my heart failure gone? And I don't understand how my heart muscle is strong, but my heart is failing. This is for people who have heart failure with preserved EF. So what's in a name? We call it heart failure. Interestingly, in some languages, they call it cardiac insufficiency, which may in fact be a little gentler term. Heart dysfunction is a little bit hard to say. handicapped heart would make a nice picture, but it's sort of a mouthful. Cardiac limitation is too vague. I would suggest that we are actually seeing more cardiomyopathy, which is a disorder of the heart muscle, rather than failure. And if we called it cardiomyopathy, it might really be a little easier to get patients to kind of lock in and admit what they have and to work with it with a positive view. So there's a continuity of cardiomyopathy care that we're working towards: the diagnosis, early and sustained intervention before there are a lot of symptoms, device therapy if needed to prevent premature sudden death and resynchronize, therapy to relieve symptoms and improve function. But as this disease advances, then we move into triage of heart failure when appropriate for advanced therapies like transplant and VADs. And then we have to provide guidance for the journey through changing goals of care for end-stage disease. So when you think about chronic heart failure, let's think about the last patient that you admitted with a diagnosis of heart failure. And think about what really bothered them. And chances are it was one of these symptoms. Either so they have dyspnea, orthopnea, anorexia, abdominal symptoms, edema, and these, the first ones, are due to elevated filling pressures on the left. Anorexia and abdominal symptoms are the major symptom in about a third of hospitalizations, and that is on the right. Sorry for the frame shift here. Fatigue and trouble concentrating are really the only symptoms we could easily attribute to low cardiac output. So it's important to get away from this idea that heart failure hospitalization is usually a low output state, because usually it's a congested state. So this has led to the hemodynamic profiles that you've heard about, where we very simply classify people in a 2x2 table. Do they have congestion at rest? Yes or no. Do they have low perfusion at rest? Yes or no. And then we put them into the warm and dry, warm and wet, dreaded cold and wet, or cold and dry based on these profiles. The diagnosis of congestion becomes relatively straightforward, but there are a few surprises, I think, for people who don't see this every day. The symptoms are pretty clear. Orthopnea is the most reliable symptom. Immediate dyspnea on light exertion. Bendopnea is a new one described by Mark Drasner at Texas, which is discomfort in breathing and a feeling of fullness in your head when you bend over, particularly like to put on your shoes. Abdominal symptoms, peripheral edema, those are the symptoms. In terms of signs, rows are very rare in chronic heart failure because the lymphatics compensate to keep the lungs empty. The elevated jugular venous pressure is the most helpful sign of elevated filling pressures. This is unfortunate, I know, because it's not that easy to learn, but I would strongly counsel all of the young people out there who are learning, you need to learn to read the jugular venous pressure, and if you don't do it in everybody, you won't be able to do it in the people who have heart failure. And edema is only present in about 25% of middle-aged people with heart failure. If we want to relieve the symptoms, it's very, very closely related to the pulmonary pressures. This is just a slide showing the proportion of patients who have relief during their hospitalization related to the decrease in wedge pressure during therapy. The bigger the decrease, the more likely they are to have significant improvement in pressures. So if you want to make them feel better, you get those pulmonary pressures down. And in fact, it's the decrease in filling pressures much more than any change in cardiac output that makes people feel better and that makes them live longer in the hospital. This is data from Greg Fonerow from a long time ago showing that if you divide the people who get to a normal wedge pressure in the hospital from those who have a persistently elevated wedge pressure, even though both these groups started out with an average wedge pressure of 30, there's a much different survival in those patients who got to lower filling pressures. Compare this now to the change in cardiac output. The people who got above and below the median cardiac output, very little difference on the ultimate survival. So what's really important is getting those filling pressures down in heart failure. So we really want to take the congestion out of heart failure as a central part of our therapy for heart failure. Most of the patients that you see and we see are the warm and wet profile, the cold and wet being much less common. These are patients who have reasonable perfusion, even if not normal, but they have elevated filling pressures that we need to reduce. If they're cold and wet, you can't just dry them out. You basically have to warm them up and then dry them out. Whereas if they're just wet, we just dry them out. It's a little like dermatology that way. So cold and wet are the sickest patients, and they're the hardest patients to treat. Dry and cold are uncommon, but surprisingly comfortable. They just can't do very much. So if they have a low output, but their filling pressures aren't severely elevated, they'll usually feel okay at rest, and they're not that likely to be admitted. Let's just go over for a moment the basic physiology of a big ventricle. This is a heart removed at the time of transplant. This is a normal-sized heart. As you can see, they get really, really big. So if we look at the arithmetic of heart failure, we focus a lot on ejection fraction. And if we think about the overall stroke volume is the ejection fraction times the LV volume. So if you take one of those great big hearts, even though the ejection fraction is only a quarter normal, if that heart is 4 times normal, you can have a good stroke volume. The problem is that so many of these people have mitral regurgitation, so some of that stroke volume is actually going backwards and is not effectively perfusing them, but is loading the lungs. So reduction of filling pressure is associated with relief of symptoms, decrease of mitral regurgitation, decreasing neurohormonal activation even without neurohormonal therapies, better exercise tolerance, and longer survival. So let's think a little bit now, more practically. We've got this patient in the hospital, and now we're transitioning from intravenous to oral therapies. And I know Dr. Joyce and your colleagues have really focused on these issues of decreasing readmissions. And we found that it helps us most to actually focus on the day we switch from IV to oral diuretics to try to get everything in line, because if you try to do it that last day when they're putting their shoes on, a lot of times we miss things. So you need to seek complete decongestion, and this is one of the places where we all fall down sometimes, is that we send them home a little wet, and then they're likely to come back pretty soon. We obviously want to adjust the therapies to alter disease progression, and our pharmacists have been amazingly helpful in making sure that we do this in a systematic way and that patients understand their medications. Plan the home diuretic dose, have a first response dose for when you need to increase it. What are you going to increase it to? Obviously, continued patient education and activity and exercise, and the discharge appointment. So doing this, why are so many of us facing this kind of readmission rate of 50% at 6 months? Horrible. And this is about the same rate in academic centers, and when we do clinical trials in the NIH, we're seeing about this amount, even with what we think is the best we can do. So moving down our key points now, let's look at rehospitalizations and what we can do further about these. Well, congestion at discharge is a very strong risk for rehospitalization. Whether you look at the signs and symptoms, these are patients with no early symptoms of congestion. These are patients who develop early symptoms shortly after discharge, and their rate of freedom from events. If you look at their pulmonary capillary wedge pressure, as I showed you, if they go home with a high wedge pressure, they have much higher event rate. Or if you measure natriuretic peptide levels at discharge, those with the higher natriuretic peptide levels, much more likely to have events. So this issue, you want to get them as decongested as possible before they go home. Well, what brings people back in the hospital? Let's think about those symptoms again. Well, no surprise, it's the same things that brought them in the first time. 70% of people with orthopnea, 85% dyspnea on light exertion, a third abdominal symptoms, edema 60%, any of the above about 95%. So they come in with the same wet symptoms they came in the first time. So what's happening? Well, early studies looking at patients with investigational monitors that monitored their filling pressures showed that if you look at PA pressures, at the time they go home, they're here. The time of heart failure hospitalization, they're here. When they go back home again, they're here. So it's a rise in pressures that comes along with hospitalization. So if this is happening, why can't we pick this up when we follow these patients after they go home? Well, think about how we try to do that. When patients go home, how do we try to monitor them to make sure that these fluids aren't coming back? Well, we thought weights worked. And I have to say, I used to be one of the most ardent proponents of the weight. And we thought they worked well because in the hospital, the weights correlate very well with the changes in fluid. And because weight-guided management is so much better than nothing. You tell them to monitor their weights, their weight goes up 2 pounds, they double their diuretics. It's certainly a lot better, and Debbie, you know this well from following these people. That's the best we have, and that's certainly a lot better than not monitoring anything. And because when it didn't work, we blamed the patients. We said, well, you need to get a new scale, you need to get a scale with bigger numbers, you need to get a scale that talks to you. We kept thinking that somehow we should be able to make this work. A number of very large trials looked at having telemedicine to monitor the weights and send them directly to the practitioners every day. several big trials, about 3,000 to 4,000 patients demonstrated on top of good management like you usually do, to do this everyday telephone thing doesn't in general increase it that much more over that. So why is that? Why can't we get better at that? It's because we really need to make sure we have a good signal. If you think about what happens, the weight will stay stable if the patient starts eating less when they feel less well. So their liver gets a little congestion, their appetite goes down, they have early satiety, they don't eat so much, so they lose real body weight, but gain fluid weight, and the whole thing stays even. So you can miss it entirely. On the other hand, we see people who go home and they feel much better and they eat more, and now their weight goes up. So if we're going to increase their diuretics, we may actually put them in renal failure because they're actually not wet at all. And edema is relatively unreliable. By the time you have edema, you've usually got at least 4 pounds of extra fluid. So if we wait for the edema, we may also be too late. They're a lot better than nothing, and it's what most of us use for most of our patients. But when it doesn't work, we need to think about what might work better. When we look at these filling pressures, this is 2 different major trials with 2 different ambulatory devices to measure filling pressures. This one measures the RV diastolic pressure. This one measures the pulmonary artery diastolic pressure. And you can see that about 4 weeks before a heart failure event, the filling pressures start to go up, regardless of which trial or which device. And it was the remarkable parallel nature of these curves that convinced me that this is a real physiologic truth, that these filling pressures rise weeks before the patient actually has an event. So if we want to keep the congestion out of heart failure in those patients who continue to have readmissions despite our best weight-guided management, we may not be able to rely on weight, and I'll use Yoda with his unusual syntax, to act in time, wisdom it is not to wait. So some people, the weights just aren't going to be enough. So if we look at ambulatory monitoring of pulmonary artery pressures, and this is the catheter-based system that we're currently using, although there will be others, this is the CardioMEMS system. Implanted, the device looks like this. It's implanted by our interventional cardiologists, in some places by electrophysiologists, and then the patient measures it on this pillow at home, and the goal is to get the pressures down and then to make sure they don't go back up again. This is the CHAMPION trial, demonstrating the remarkable decrease, about 30% decrease in hospitalizations over the period of 6 months, and then again looked at later, of those patients who had a monitor but you couldn't look at the information versus the monitored patients. So if we look at the decrease in hospitalizations, all-cause hospitalizations markedly decreased by monitoring, as well as the specific heart failure hospitalizations. Interestingly, patients who have chronic pulmonary disease had a decrease in pulmonary hospitalizations as well, demonstrating that very tight interaction between the pulmonary circulation and symptoms and the heart. Our early experience with real-world monitoring is that the pulmonary pressures are often much worse than we thought. We thought, well, we're doing pretty well with this patient, put the line, oh my gosh, it's really high. So we were able to pick up some people in whom they were at risk, but we didn't appreciate it. That you can, in most patients, get to a lower pulmonary artery pressure plateau and maintain it over time. What the nice thing, too, is when you pick it up early, you can just change the diuretics a little bit. You don't have to have this big blast of diuretics. And the patients are learning. This is fascinating to me. Over time, the patients, when you call them and say, your pressures are high, what were you doing? And they can remember that they had Chinese food on Saturday night. What they can't remember when they come in the hospital is they had it a month ago. So this is an example of a patient, what I call a pretty fast learner. These are pressures when he went in. And these are during various episodes. Going here, this is a hot dog and fries. This is a BLT sandwich. And basically, he got to where he would predict what was going to happen, but overall, his pressures are now much lower than here, I think because he's having fewer hot dogs and French fries. In the real world use with a PA pressure monitor, it is also very effective. This shows the decrease in PA pressures over the first 6 months in the first 2,000 patients with the approved device. This is the trial, and this is the control in the trial, and the monitored patients, and you see it's so much more dramatic. That's because the patients now know the information. You tell them when those pressures are too high, and the patients who are caring about their health, they start to figure out what to do. And we're hoping eventually this will be kind of like monitoring glucose. You measure your pressure and you adjust your own medications according to an algorithm that we give patients so they can take care of themselves. We're not there yet, but that's sort of the ultimate vision for how we might really be able to improve this. So let me just comment a little bit about evolution of medical therapies. This is where we were a few years ago. We had diuretics, ACE inhibitors and ARBs, recommended for all the patients with low EF, beta blockers, recommended for all the patients with low EF, aldosterone antagonists for those patients who could tolerate them without hyperkalemia, with good renal function. A little secret from the guidelines, the longer the guideline, the more disagreement there was on the committee. So if it takes all that many words to get people to approve it, it's because a lot of people have concerns, and people still have concerns about the aldosterone antagonists and the risk of hyperkalemia. And hydralazine nitrates for the African American patients who still have symptomatic heart failure. So then along comes Entresto. There's clear and substantial benefit documented in terms of CV deaths, heart failure hospitalizations, all-death heart failure hospitalizations, about a 20% decrease in all of these. So now what do we do? Well, it gets kind of complicated now. This is where we started from, and this is what we're trying to do, but when Entresto comes in, now we're going to replace ACE and ARBs in some patients with Entresto. Bear in mind it's a vasodilator, so we don't really know what we're going to do with hydralazine and nitrates. It often changes diuretic requirements because it's a natriuretic effect as well. So it's going to be very complicated. And when we look at it, the individual effects are very difficult to predict because it's such a complicated molecule. As you know, Entresto is a combination of an angiotensin receptor blocker and an inhibitor of neprilysin, which leads to increased natriuretic peptides. And just of interest, looking at a patient who had a pulmonary ambulatory monitor in, this is what happened within his first couple hours after Entresto. These are 4 different patients, and you can see the patient who started out with the highest pressures had the biggest decrease in pressures. Patients who had pretty normal pressures, not much change. It's a very early experience, but just demonstrating it's going to be complicated in terms of different patient responses. So the new guideline now reads that you can use any one of the 3, ACE, ARB, or ARNI, but in patients who are doing pretty well on an ACE or ARB, that we would recommend replacing it with an ARNI. I don't think we know enough yet to know how often that will be possible and with what doses. I think that it's going to be a very interesting era in heart failure because we've had this stepped concept that you just start with this and you add this and you add this and you add this until you're done. But now we're going to have to start juggling these medicines as we add a medicine like Entresto or ivabradine so that it's going to become much more of a challenge to tailor therapy for the individual patient. I also want to put in perspective for you the impact of Entresto. This is all the major heart failure trials we've ever done, starting at VHEFT over here, going through the beta blocker trials here, the trial with mineralocorticoid antagonists here. You don't need to look at the details, but the 2 curves are the 1-year survival with and without the medication. And this is Entresto shown here. So I just want to put in perspective that this is a very positive therapy with lots of it, but it's not huge, okay? It's not as though it goes from 1-year mortality of 50 to 20. This is a relatively healthy group studied with a 1-year mortality in the control group of about 8 to 9%. So just to put it all in perspective when we compare our therapies. And this is just a complicated slide. Don't look at any of the details, but this is just to look at all the different things that this drug may do. And you can certainly imagine it could be very different between patients. So no matter what recommended therapy we look at, I think it's important to recognize that we have to individualize the therapy. And this is a patient saying, I think the dosages need adjusting. I'm not nearly as happy as the people in the advertisements. So now I just want to move on for a moment and discuss the progression of heart failure with preserved EF and its similarities to heart failure with low EF. Well, we think about them as being very different diseases, sort of like apples and oranges. But in fact, apples and oranges aren't that different either. They're both edible, they're both fruits, warm color, round shape, they contain seeds and grow in trees, and they're good for juice. The names begin with a vowel, need similar pesticides for both apples and oranges, and they're unsuitable for most sports. And heart failure with preserved EF and heart failure with low EF have a lot of things in common as well. I do want to put in just one piece of newer data about this as well, which is some very nice data coming out of the Mayo Clinic showing the patients who have heart failure with preserved ejection fraction and obesity may have a slightly different flavor of heart failure. You can document more plasma volume, higher PA pressures at rest and with exercise than people who have heart failure with preserved EF without obesity. So we may begin needing to look at those two groups slightly differently. One of the things that's been said about heart failure with preserved EF is that they flash. They're totally fine, middle of the night, all of a sudden they're short of breath and they flash. In fact, if you look at the same sort of PA pressure monitoring in these patients, it's not so fast. This is looking at heart failure with preserved EF, and over here the axis, this number here is 27, so it's a truncated axis. And although the pressures are a few millimeters lower, you can see the same trend, just slightly shorter, about 21 days before an event. Those pressures start to go up. So it's really not flash flooding. The pressures go up slowly, but they become clinically impactful just very quickly. And if you look at the benefit of PA pressure monitoring, if you look, this here is the heart failure with reduced EF. This is the heart failure with preserved EF. This is the control, the treated. So there's a hazard ratio of about 0.5. So we're decreasing heart failure hospitalizations by about half with ambulatory pressure guided strategies in patients who have heart failure with preserved EF. So this finally is an intervention that seems to decrease hospitalizations on top of the usual therapies that we have. I'm going to just mention now the progression. If we look at all cardiac disease, again, looking at the current era, what are we seeing? And this is enhanced survival with contemporary therapies for all cardiac disease, post-infarction particularly, as well as non-ischemic cardiomyopathy, but they do survive to develop chronic heart failure with reduced EF, and many eventually develop right ventricular failure, cardiorenal syndrome. The aging population, we have more heart failure with preserved ejection fraction. We have new survival with non-cardiac disease like cancer therapies, HIV therapies, and of course, longer survival with primary pulmonary hypertension. But many more of these paths are converging into right ventricular failure before the end. So the right ventricular failure is becoming the tipping point for people with heart failure. You do okay even with a low ejection fraction until that RV starts to go. If we look at heart failure with reduced ejection fraction, this is the PA pressures along the bottom, and this is looking at RV function. RV function clearly declines as those PA pressures go up in heart failure with low ejection fraction. The same thing is true in heart failure with preserved ejection fraction. This is looking at PA pressures. The higher they get, the lower the RV function gets. So one of the important things about trying to pay attention to these PA pressures is that we may be able to better protect and preserve the right ventricle if we can prevent this load from the left side. So we'd like to keep the RV failure out of cardiomyopathy. But of course, heart failure often does progress and the tide comes in. We think a lot about the transplants and ventricular assist devices, and they're the most glamorous therapies, often very dramatic results. On the other hand, we know that most patients are not eligible for these in terms of comorbidities, age, social support, other problems. And so we need to make sure that we continue to focus on the other patients as well, of whom there are many more, and whom we're going to just have medical therapy for the rest of their lives. If we look at the hospitalizations with heart failure from the time of the first hospitalization shown here, divide their whole life into deciles, and look at the frequency of hospitalizations, regardless of how long they live, this is what the overall curve looks like. There's a bump after that first hospitalization. Those are the readmissions that Dr. Joyce, and I noticed Dr. Cohen's poster as well, that we're working hard to decrease. Then we move into this plateau phase, where new ways of trying to monitor patients at home over time will be helpful. But many patients eventually go into this high hospitalization phase towards the end of their lives. And in those patients, we focus on palliation of their symptoms and helping them determine what their priorities are in order to enjoy their remaining life as much as possible. So just to conclude the key points, the journey with heart failure has changed. And maybe the name should change also. Consider more of it to be cardiomyopathy. Congestion dominates the typical symptoms. Rehospitalizations are usually recongestion, unless they're for arrhythmia problems, such as our colleagues up here know about. Managing pulmonary pressures lowers event rates. Progression of heart failure, regardless of your ejection fraction, it has similarities, and certainly the pulmonary pressures and RV failure is a final common pathway that we would like to be able to avoid. But finally, we will still walk patients home. Thank you very much.
Dr. Stevenson, thank you so much for an excellent and comprehensive presentation. Just to point out to everyone here that we are working at the medical center to have cardio MIMS hopefully in another month or two, and also that our readmission rate has actually drastically dropped in the last 6 months or so. We have seen, and these are for the residents and the hospitalists out there, that patients who get hospital follow-up post-discharge within a week, that those readmission rate also is much less than patients who take 2-3 weeks to see for follow-up with their cardiologist and or their primary care. Thank you.
Dr. Joyce, did you want to comment? I know you've been very effective, and I'm quite admiring your work and how you've integrated your role here.
First of all, it's not just my work. I have a wonderful team led by Dr. Dawson. And one of the things that we have found, as Dr. Dawson mentioned, is that importance of that follow-up appointment. But also, in addition, it's the education. And we've been spending a lot of time with our patients educating about heart failure. And I'd love to hear some of your comments of what you've learned over the years with working with heart failure patients. We find some that are very motivated. They want to learn, they want to know more, and then we have some that are almost in a denial stage. And that makes the education so very difficult to try to make it for all of our patients. So I'd like to hear some comments of what you've found that's been helpful with educating our patients about their disease.
I completely agree. I divide patients really into 3 groups. There are the ones who are really invested in their health. They're the ones, no matter what you do, you can't get them invested in their health. Something at some point may scare them in the future, but if this hasn't, I don't know what will. And then there's the group what I call the willing but weak-willed, who they kind of want to take care of themselves. They don't want to be sick, but, it's hard to remember to take your medicines, and it's hard to weigh yourself every day. And those patients, I think, are the ones that we can help the most. By giving various incentives, by trying to make things easier for them, by giving them a lot of positive feedback and some of the social media, for instance. I think that's our real target group. In terms of other things that we've found help compliance with our pharmacy colleagues is really talking to the patient to find out what bothers them about their meds. Because often they don't want to tell you that there's something that they don't like about their medicine. For instance, you'll have some people who may have a job that goes from 8 to 4, so they don't want to take a diuretic in the morning. So then you talk with them and figure out how to do it either at 4 in the morning and get done before they go to work, or 4 in the afternoon. It turns out, and this is actually something we've learned from the pressure monitoring, that the lowest time for many people in the day of pressures is about 11 o'clock. Because we tend to give them everything in the morning, and sometimes it all kicks in and they feel kind of blah and a little wobbly around 11, but they're not attuned enough to say, oh, I have postural hypotension. They just say, I just feel kind of crummy around 11. Then they find if they don't take one of their morning meds, they feel better. So I think in those patients, we often switch the vasodilating medicines to nighttime. So I think it's very helpful to really let them express what bothers them, because sometimes you can do something about it.
One of the other things that we have found along with with education, I think probably one of the other things is just making sure that patients do have access to their medications. Mm-hmm. And with some of the newer medications, I know the cost can sometimes be an issue, but there are many programs that are available that can help to offset the cost for those patients.
One of the other things that our pharmacists have taught us is that our pharmacists work together with our nurses and contact everybody within 72 hours of discharge by phone. And we've been appalled to find out in Boston that about a third of patients go home with something wrong with their medicine. Something's prescribed at the wrong dose, something's prescribed that they shouldn't be on, or that they haven't gotten what they should be on. So I think we have to have so much effort into making sure that that reconciliation is there. And I'm sure you have the same problem where you are when residents and fellows come and go and they don't necessarily know the patient over time, is that reconciliation is really, really vital. Our pharmacists have taught us that.
Dr. Stevenson, with devices like CardioMEMS that monitor the PA pressures, do you think you have any ideas about the cost of these procedures, and how do you select the patients, at which repeat hospitalization do you decide that, this is a patient who might benefit from getting a monitoring device, and also if you can comment on if you think that it's a good idea to do it more as not an individual decision, but a group of physicians sitting together, bring up cases that, along with the other people involved in the care. This is a patient coming in for the 4th time this year. What do you think should we look at? Should this be something that should be dealt in that way?
It's a really good question. I think you have to look at the whole picture of what it requires from the patient. First of all, the major error that I see both in my own colleagues and elsewhere is putting it in too late. If you're putting it in somebody whose creatinine is always up at 3 or 4, or someone who's already on 200 atorsomide twice a day, knowing that their pressures are high, you may not be able to do anything about it. So it needs to be someone who is still well within the responsive range, not end stage. End stage, it doesn't help. And one of the analyses done has shown that if you have a patient who no longer tolerates ACE inhibitors and beta blockers, they don't benefit from CardioMEMS either. So it's that person in the middle. And I think as soon as they've had one hospitalization, unless there's some reason to think that their whole disease is going to turn around, like peripartum cardiomyopathy, for instance, it's reasonable to think about it after that first hospitalization if the disease is truly chronic. But the mistake is don't put it in too late, because then everybody's going to be frustrated. I think part of what I'm hoping as well over time is that by learning from these pressures, we may also learn more about easier ways to follow patients than necessarily having an implanted device, so that we would end up with not everybody needing an implanted device, but coming up with more understanding of the physiology that will help us with people that we don't monitor.
Just to add to that, Dr. Stevenson, I think the group of patients that will make the biggest impact will be the 1/3 of patients who are almost compliant. They just need a little nudge. And if these are the ones who know that, they are just falling off the track, and they are motivated to treat, get compliant, I think they'll have the biggest impact with such devices, rather than those who are on the are outliers, is what I think.
Exactly. If they don't care without the device, they're not going to care with the device. But it's the willing, weak-willed who are perfect for this. If you can prove to them that Chinese dinner made their pulmonary pressures go from 20 to 40, now you've got them. And and we see these patients, that's our favorite phrase. One of our CardioMEMS nurses, she goes, and she says, "I gotcha." And they say, "Yes, you did. You caught me. I thought I could get away with it." One of the things I suspect, and I don't want to know yet, but I'm going to want to know soon, and ask patients, I think patients learn that after they have something they shouldn't, that they may take an extra Lasix. I can tell you for sure what they do. If they have one bad day, they know they better have a really tight day the next day in terms of their salt. It's really interesting to see how they begin remodeling their behavior, because they don't want you to call them and tell them the pressures are up.
While Dr. Vashis comes, just to point out to another big thing that we see in these patients, probably about 60 to 70% is depression. So we really need to also treat this comorbidity as well. What are your thoughts on that?
I agree completely. I think it's very important to try to sort through what the cause of the depression is. In some cases, it's related directly to their disease, in that they can't do what they want to do. And often in those patients, you want to say, what is it you really want to do? And try to figure out some way they can do that, give them more hope. In other cases, it's side effects from the medicine. They're really dizzy and they don't want to walk around, in which case you treat that by cutting back the doses. And then in some cases, it's just depression because people have endogenous depression for other reasons. So I think it's really important to start and parse out what we might be doing or what the disease might be doing that's making the depression worse versus endogenous depression. But I agree completely. It is a major factor, and often we don't fully appreciate it because they come in and they want to look well for us.
Thank you for a very good talk. My question is twofold. One is that have you noticed, or in your experience, in terms of the payers for paying for these procedures, how easy is it for these to get approved? And second, have you noticed in long-term follow-up with these patients that there is sort of burnout? Because there is a lot of compliance issues with the patients. They have to lie on this pillow every day and have to transmit the you have to get the pulmonary pressures get transmitted. Do you see that paradoxically sometimes patients say, well, there is a doctor who's monitoring my pressure, so I can probably go eat the Chinese food and I'll just have someone call me. There's actually a YouTube video on one of the patients saying that, well, now I can do what I want because my doctor's monitoring it every day, so I'll change. Have you noticed that paradoxically it works that way as well?
Let me answer your first question, which is that it's a nightmare. Reimbursement is a nightmare. And you're in one of the worst regions for reimbursement at this point in terms of this sort of CMS ambiguity. So yes, that is a problem. When it's approved, in fact, with the new reimbursement that began in January, from a hospital standpoint, it's very easy to make this a reasonable procedure as long as you do it as an outpatient. Don't do it as an inpatient because then it competes with your DRG and you're in trouble. So you really have to limit it to the outpatient. And since January, if you can get it reimbursed, the reimbursement is really quite adequate to compensate your cath lab staff, et cetera. In terms of the burnout, post-approval, well, actually in the trials, we measured how often the patients transmit, and 95% of the patients transmitted at least once a week in the trials till the end. And we're seeing about the same thing in the post-approval, the first couple of years, that 95% are transmitting at least once a week. And then if something's high, then they transmit more often because we call them and tell them to transmit until we make sure that pressures come back down again. So we've not really seen burnout in that sense. In terms of it allowing some license, it may happen, but in fact, I'm really pleased if they got the concept that they do something and something happens, and then something that leads to something else. That's a huge loop if you can get that in their head. So even if it makes them a little less careful, I think taking some of the mystery out of it helps them and us.
Thank you.
Can I just ask one more question to address the team? I'm sorry. Thank you, Dr. Stevenson, for coming. My name is Ming Lan. I'm a second-year psychiatric resident. In my short 9 months up in the psychiatric unit, I've seen 3 patients that decompensated cardiac with the psychosis. Most recently, we had a patient that came in acute mania, and in her history, in the past 2 months, she was admitted to a different hospital for a cardiac failure, and then in that case, they had stopped her antipsychotic medication and her depression medicine, her mood stabilizer. When we had her, we started to put her back on her home dose, lithium, and some other psychotic medication. From there, we saw another delirious case that came up, and what we found was actually a medication interaction from her ACE inhibitor and ARBs with her psychosis, with her lithium. I would like your advice and your input, because what Dr. Dawson said, there are depression that we see, that you guys see in cardiology. What we also see in these mood disorder patients or psychosis patients, we can't just eliminate one versus the other. We've got to look at both. And what's your thoughts and advice on that?
I'm very glad you brought it up because I think we need to be reminded all the time of the importance of these other medications. My feeling is that quality of life and mood, that's what it's all about. So I almost never stop any medication that's for a psychological or psychiatric reason unless I have some kind of substitute. So I think you're exactly right, and any reflex to stop those medications is clearly a reflex that we need to suppress. because we have to keep them on their medication. So I agree completely, and I appreciate your reminding us of how important that is. I'm sorry, was there another part to your question? The balance is that if you're depressed or manic, then I don't think much else matters. So we want to treat that with whatever medication works best. And for most medications, in terms of any cardiac problems, we worry a little bit about QT prolongation, but much less now that we have ICDs in most patients. In terms of interaction with ACE, ARBs, and lithium, I don't actually have many patients on lithium at all. So I've never messed with it, and I haven't seen the mania. But certainly I would probably move to change the ACE or ARB before stopping the lithium in somebody who needed it to suppress manic disorders.